So hello, in this video I'm going to talk about the anti-influenza drug which is called Oseltamivir, and that's its full proper name, but it's more commonly known by its original brand name, which was Tamiflu, which was made by the drug company Roche. So this is a medication that is only available, I think, in the oral form. I don't think there's any intravenous or parenteral form of it at all. It's just an oral tablet medication. In fact, I think it's a capsule usually rather than a tablet, but an oral medication that is used to treat influenza virus infections. And the first thing I want to discuss is the difference between influenza and flu, because often we would say oseltamivir is used to treat flu, but when we say flu, we're really meaning influenza, flu caused by the actual influenza virus. So this word flu, it's much more broad than just referring to infections caused by the actual influenza virus. So flu is what we say when someone has a respiratory tract infection, usually an upper respiratory tract infection. If it's gone lower down, then it might no longer be called flu. It would be called influenza pneumonia if it was caused by influenza, or pneumonia if it was caused not by influenza but by bacteria, or viral pneumonia if it was caused by some other virus other than the influenza virus. So I might just draw a little picture here. So if we have a human, this is going to be quite a bad picture. Here's his neck, here's his arms, and then there's legs. And in the chest, of course, there are the lungs, which I'll draw there. And then from the nose, up here, and the mouth, there's passageways that go back and they join in the pharynx, and then the pharynx comes down and goes into the larynx. Well, the pharynx splits into the esophagus that goes behind, and then the larynx that comes forward, and the larynx goes down into the trachea, and the trachea then goes down into the two main bronchi, which enter the lungs, and then they split up into loads of tiny little airways, and then they filter off into the lungs. And this is, of course, how we breathe. The air comes in, hopefully, for our nose rather than our mouth, but if you're mouth breathing, then it will come through your mouth as well as your nose, and then it goes down into the larynx, into the trachea, and then down into the two main bronchi, and then into the smaller bronchi, and then the bronchioles, and then to the actual lung tissue where gas exchange actually happens. So this is the respiratory tract, this passageway from the outside world down to the actual lung tissue, the alveoli here. And this is very, very vulnerable to getting infected, and such an infection is called an RTI, respiratory tract infection. Now, we split respiratory tract infections into upper respiratory tract infections and lower respiratory tract infections, URTIs and LRTIs. And upper respiratory tract infection means infection of maybe the nose or the throat or the larynx, or maybe even the trachea, although you're starting to get to the point where maybe it might start to be counted as a lower respiratory tract infection if it's got into the trachea. Then if it goes further into the actual bronchi, and then maybe even the bronchioles, then it's called a lower respiratory tract infection. And lower respiratory tract infection is much worse than upper respiratory tract infection. We get upper respiratory tract infections all the time. Every time you get a cold, if you get a runny nose from a virus, that's a cold, that's a type of upper respiratory tract infection. That's where the virus is infecting your nose, and that's why you've got a runny nose. If it goes back and causes a sore throat, then it's caused pharyngitis. That's also an upper respiratory tract infection. That's, it's got a bit further down, that's a bit worse. Then if it causes you a sore throat and hoarse voice, then it's got into your larynx, laryngitis. That's another example of an upper respiratory tract infection. And if it gets down into the trachea, that's called tracheitis. So it really causes a very barking sort of cough when it gets into the trachea. Laryngotracheitis, which is the combined word for inflammation of the larynx and the trachea, that's classically got this sort of barking, seal-like cough. And that's probably the end of where we would call it an upper respiratory tract infection. If it gets down into the bronchi and the bronchioles, then it can cause you, well, it will cause a bad cough, but it will also potentially cause you to start becoming short of breath. It might cause the airways to start contracting down a bit, and then you become wheezy, and that's getting more serious. Then, if the infection actually gets into the lung tissue proper, that's then called pneumonia. So all of these are examples really of respiratory infections, upper respiratory tract infections, lower respiratory tract infections, and then pneumonia. They're all respiratory infections. And the order of severity is this is least severe, then this is more severe, this is most severe. So when we get viruses all the time, which we often do, we might get a bit of a runny nose for a few days and then we beat it off. These are upper respiratory tract infections. And when you get only a very mild one that might just cause you a runny nose, maybe a sore throat, then you call it a cold. If it's worse, maybe it gives you a really bad sore throat, hoarse voice, really bad cough, and you're really feeling really quite ill and you stay off work and you go to bed, then you might call that flu. So these words, they refer to upper respiratory tract infections. Cold is what we call an upper respiratory tract infection when it's not that bad. Flu is what we call it when it is bad. So that's the way that we use them all the time in real life, these two words, cold and flu, because we do not get a viral swab to actually identify what virus is causing the infection. So we do not know whether we've actually got the influenza virus that is causing our symptoms. So the whole point of this explanation is to explain that there is a difference between flu and an actual influenza virus infection. When you have a bad upper respiratory tract infection, it does not mean that you necessarily have an influenza virus infection. There are loads of other viruses that cause respiratory tract infections. Some examples are, for example, adenovirus. There's loads of adenoviruses. They cause respiratory tract infections. They're very common causes of colds and what we would call flu, upper respiratory tract infections. Rhinoviruses are another example. What other ones? Metapneumovirus, which sounds quite scary, but it is a common cause of colds and flu. And then, of course, the coronaviruses, made famous by the one that has brought the whole world to heel for the past 3 years. But there were loads of coronaviruses before that one. And they still exist and they cause upper respiratory tract infections. They go around and cause colds and flu in people. So flu and influenza does not mean the same thing. In hospital, when people have respiratory tract infections, and of course people don't usually get admitted for upper respiratory tract infections unless, they've got really bad pharyngitis that has then got secondarily bacterially infected and maybe they now have like an abscess behind their pharynx. That might warrant admission under ENT. But people don't usually get admitted to hospital with upper respiratory tract infections. People usually get admitted to hospital with lower respiratory tract infections and pneumonia. And these viruses, influenza viruses, adenoviruses, rhinovirus, maybe not rhinovirus, but metapneumovirus and coronaviruses, they can all cause lower respiratory tract infections. And in some people, they can even cause pneumonia. And in that case, it's called viral pneumonia. Pneumonia is more often bacterial than viral, but you do see viral pneumonia. And of course, that's what has been a massive issue these past 3 years, that this new coronavirus, COVID-19, SARS-CoV-2, had a massive proclivity to actually cause pneumonia. So we had massive problems with corona pneumonia. So viruses can cause pneumonia. But more normally what happens is, say you get influenza, you get a really bad respiratory tract infection, upper respiratory tract infection turns into a lower respiratory tract infection, it massively weakens you. And then your body can't defend itself against the normal bacteria that we breathe in all the time, and then those bacteria up a secondary infection that's actually in your lungs. So often influenza can trigger pneumonia, but it's not actually that the influenza virus has directly triggered the pneumonia and is directly infecting the lung tissue itself. It's that it's made you really sick and then you've got a secondary bacterial pneumonia. And the same is true of all these other respiratory viruses as well, that they can trigger secondary bacterial pneumonia. And that's particularly common in elderly people over young people. It's unlikely that if a young person, let's say a 18-year-old, gets influenza, they almost certainly will not get pneumonia from that. They'll get a bad upper respiratory tract infection unless they've got pre-existing health conditions or they're on immunosuppressants or something along those lines. But an immunocompetent young person shouldn't get pneumonia from these viruses. It's much more common in elderly people whose immune systems are not as strong. Right, so that's the difference between influenza and flu. So you do not just use this drug to treat flu. You use it to treat actual influenza infections. It is no use against these other viruses that might be causing clinical flu. It's only useful in actual influenza virus infections, which means that really In this country, certainly, I don't think it's widely prescribed in primary care. I think in other countries, they do sometimes hand it out to people who come and complain of having bad upper respiratory tract infections in primary care. Then sometimes they give them Oseltamivir on the basis that maybe the infection is actually influenza. I don't think that's a big thing that's done in this country, this country being the UK. In this country, I think we would only give it to you if you've actually got confirmed influenza, because it's got side effects, this drug, and it's even against actual proper influenza infections. It's debatable how actually effective it is. You know, there's been debate, I think, recently about whether this drug actually has a decent effect, or whether it's not really that effective at all in helping fight this infection. It is still, you know, something that we do prescribe, so at the moment the current position is that it does have a benefit, but it is debated, know that. But it has side effects, certainly, and in someone who has just got an upper respiratory tract infection that may or may not be actually caused by the influenza virus, they're probably going to get better as long as they're immunocompetent. They're going to get better by themselves. So this drug is probably going to have absolutely no benefit to them having it, because their infection probably isn't influenza in the first place, and even if it is influenza, if this drug is debatable how effective it is. And then it has side effects, and we'll go through what the side effects are. In fact, I'm going to talk about the side effects now. So we'll talk about side effects. So you can look these up, but I'm going to talk about ones that I've seen people get multiple times. So I've looked at the ones in the BNF. The BNF talks about how it causes nausea, but in some people how it causes diarrhea, gastrointestinal discomfort. I don't see that a lot. Like, I've never seen anyone get sort of like, I mean, certain antibiotics are awful for causing GI disturbances. You know, doxycycline, clarithromycin, erythromycin, these ones are awful for giving people like epigastric pain. They really irritate the stomach. And other ones are awful for causing diarrhea, like augmentin is really bad for causing diarrhea. So antibiotics, you see massive GI disturbances very, very commonly. But oseltamivir, I don't think GI disturbances, they're not something that I see commonly when people are on this drug. The one that I see people complaining about a lot is sleeping problems. Now, this is difficult because obviously in hospital, the patients that I see are in hospital, and you do have sleeping problems in hospital because they're not peaceful places. But I do see people with oseltamivir saying that they're having real trouble sleeping, and that they just can't get to sleep, and when they do get to sleep, they only sleep for very short periods of time, and that is a side effect that is listed as very common in the BNF for oseltamivir, so just not being able to sleep properly whilst on it. And then herpes breakouts is the other thing that I would say is a big side effect of it. Herpes simplex, again, this is listed as a common side effect in the BNF. So herpes simplex, there are two of them, HSV1 and HSV2. And they cause sort of infections of our epithelia. So classically, they cause mouth ulcers. Mouth ulcers often aren't actually caused by a virus. They're caused, you know, by you biting the mucosa and causing injury. But they can be caused by, when they are caused by viruses, they're caused by herpes simplex 1 or herpes simplex 2. Herpes simplex can also cause skin infections, so you can get like little blisters on your skin, not all over your skin, so it's not like chickenpox. So they're very closely, these two viruses are very closely related to VZV, which is the virus that causes chickenpox and causes shingles, and they cause the same sort of lesion. They cause like those little blisters, vesicular lesions. But VZV, when it causes chickenpox, causes them all over the body, so you get them everywhere. HSV doesn't cause that. It causes them just in one little area of the body. So maybe on your arm, you might get a little cluster of these little blistering vesicles, and that's not going to be a VZV infection if it's just limited to one place. That's going to be a herpes simplex infection. So they can cause skin infections, and HSV2, but also HSV1, but the textbooks will say more HSV2, can cause genital infections as well. So infections of the skin around the genitals, and also the infection on the actual mucosae of the genitals. So the undersurface of the foreskin, the surface of the glands of the penis, and then the surface of the labia, and the surface of the outer parts of the vagina. So, and also potentially the anal region as well. These can cause infections of the anus. So, herpes simplex outbreaks, they're not nice. They don't cause a massive problem, but they're not pleasant. They don't look nice. They can be a little bit painful, and that is a common side effect of this drug, that when you take it for influenza infection, that somehow your body stops being able to hold back herpes simplex infections, and suddenly you start getting symptomatic herpes infections. And of course, these will get better by themselves. They don't need treatment. They will get better as long as, again, you're immunocompetent. Once you come off the Oseltamivir, they will get better. But it's still not nice. If we go back to our person who's gone to their GP because they've got a bad upper respiratory tract infection, if they were going to be put on this drug by their GP, one, their upper respiratory tract infection probably isn't influenza in the first place, so they're probably going to get absolutely no benefit from it. But then they're going to get these side effects of not being able to sleep properly, potentially. And sleep's very important for healing, so that might have a negative impact, actually, on how quickly you get better from your upper respiratory tract infection. And then also, added to your woes, you're going to get potentially herpes infections on your skin or your mouth, which isn't pleasant. So it's just potentially something that's not going to actually benefit the person and actually harm them. So it's not something that I would give out to people coming to primary care who are well people with a bad upper respiratory tract infection. I would say, go home and sleep, watch some TV and wait for it to get better, rather than take this drug, because I think this drug will probably do you no benefit and may well make your problems worse. But the place where it is useful, where it is used, is in hospital. So in hospital, if people are being admitted to hospital, then firstly we can, if let's say they're really, really sick, so let's say they've got pneumonia. So the way we diagnose pneumonia is we take an X-ray of their chest and we can see the lungs should look nice and clear on that X-ray. They show up nice and black on the X-ray with just some sort of white markings on, which are the airways and the blood vessels inside the lungs. If you've got an infection in the lungs, then the tissue starts showing up more attenuated, more white, grey to white. Getting whiter is worse. It's a worse infection. So bacterial pneumonia and viral pneumonia look very different on chest X-ray. Bacterial pneumonia is often more confined to one lump of potentially one of the lungs, although you can get bilateral bacterial pneumonia. That would be really bad. But it's more normally in someone who's not on the verge of death, but still is quite sick. It might be confined to one splodge, and it's actually more normally in the lower lobes rather than the upper lobes. This is more sort of upper lobe pneumonia, which is rarer. So it might be a splodge down here or a splodge down here. That would be right lower lobe pneumonia, and this would be left lower lobe pneumonia. This is left upper lobe pneumonia here. So that's what bacterial pneumonia normally looks like. But if you are really, really sick, then you might have it in both lungs, huge, great splodges like that. Whereas viral pneumonia tends to be more widespread, affecting both lungs, and not so dense. It looks more sort of like widespread, sort of patchy, like clouds inside the lungs that all sort of patches of attenuation. Widespread patchy attenuation, that's more what viral pneumonia looks like. So if we have someone coming in who's got pneumonia, they're really, really breathless, their oxygen saturations are low in their blood, we're having to give them huge amounts of oxygen to keep their oxygen levels in their blood okay, and we take a chest X-ray and we see why they've got such problems with desaturation, which is that they've got some sort of pneumonic process that is patchy and affecting both lungs like this, then we will think viral pneumonia, and then we will swab them for respiratory viruses. And in my hospital, we have a nasal swab, and I think they probably swab the back of their throats as well. I don't really know because the nurses do it, or the HCAs probably do it. But they swab, and then they send it off to the lab, and the lab runs tests for like 20 different viruses off that. And these viruses here are some of the ones that are included. There are other ones as well that I have never seen come back positive, but they do test for them, and they test for influenza as well. So if they were to come back positive for influenza and they've got a chest x-ray that looks like that, negative, let's say, for COVID-19, then we might diagnose this as influenza pneumonia. And that is the situation where definitely we would put them on Tamiflu, and we hope it would have some benefit in their prognosis. We'd also put them on other things as well. We'd put them on antibiotics to cover for secondary infection, and we'd, as I say, put them on oxygen to keep their oxygen levels up in their blood. Potentially, if we can't keep their oxygen levels up on their blood just with supplemental oxygen, then we might need more fancy machines, like high flow oxygen, or potentially NIV, or potentially even intubation and ventilation if that is appropriate. Anyway, so let's now talk about the dose of oseltamivir for treatment of pneumonia. So it comes in 75 milligram capsules, and the treatment for bad influenza infections, and as I say, well, as I haven't said, it wouldn't just be for influenza pneumonia. Let's say someone's really sick in hospital with an influenza lower respiratory tract infection, or even if they're in hospital for an influenza upper respiratory tract infection where they've tested positive for influenza and they're quite ill in some way. Let's say they've got a pharyngeal abscess secondary to a viral upper respiratory tract infection that has then set up this bacterial abscess, and we find that the viral infection was influenza, then we might give them oseltamivir in that case as well. And lower respiratory tract infections, if they're really, really wheezy, they might have a background of asthma and then they've got influenza and they're really, really wheezy and not well with that, then again we could treat that with oseltamivir. So in people who are hospitalised with influenza infections, that's where I think it is very appropriate to try this drug to see if it has some benefit. So 75 milligram capsules, and we would give it, it's oral, and we give it twice daily, and it's for 5 days normally that is we treat it for. But that treatment can be extended to 10 days if they're not getting better, then it could be extended to 10 days. The other way we use it in hospital, and by the way, there is a dose adjustment according to if their renal function is bad, and I've actually got a print screen from the BNF here. So this is the BNF page for oseltamivir, and it tells you what to do if the patient has renal impairment. So EGFR, hopefully everyone watching this knows what EGFR is, but in case you don't, that is a measure of how well your kidneys work. So we do routine blood tests on everyone that comes into hospital, and one of those routine blood tests is kidney function tests, and from those tests we work out something called the EGFR, or the lab automatically works this out for us and we just get given the result, and it stands for estimated, that's the E, glomerular filtration rate, and it is basically a measurement of how well your kidneys are working. Now, in someone young with very good kidneys, it should be greater than 90. In someone who has really, really poor kidneys, it can go very, very low. So if it goes sort of like below 5, that's where you'd be looking at potentially putting the person on renal replacement therapy, so maybe dialysis or maybe getting them a renal transplant. And then in between, there's all the levels in between as well. So if you've got 60, that's not too bad. You're nowhere near needing dialysis yet, but we might want to look at your blood pressure, make sure it's not too high, because high blood pressure can be damaging kidneys. Or if you've got diabetes, we might want to get your diabetes under better control if it's looking as though your GFR is trending downwards. When it gets below 30, that's more serious. 15 to 30 is not great, but it's still hopefully you won't ever need dialysis. Once it's below 15, that's quite bad. That's sort of like refer to a renal specialist. And as I say, if it goes too low, certainly if it goes below 5, I think that they will look at dialysis. But even below 10, I think they'll start to look at dialysis. So that sort of is just a very basic idea of what the different levels mean. So what the BNF is telling us here is that if the person has an EGFR less than 10, then we should not be prescribing oseltamivir ideally, unless, of course, the benefit truly outweighs the risk. If this person is life-threateningly ill from what is clearly viral pneumonia and they have swab positive for influenza and they're going to die most likely from this infection, then we want to do everything we can, and in that case they might put them on oseltamivir after consultation maybe with a renal specialist, or just a phone call with a renal specialist to discuss it with them. But it certainly says avoid for treatment and prevention if EGFR less than 10. And then we also have this stuff here, which tells us what to do in other EGFRs. So for treatment, use 30 milligrams twice daily if EGFR 30 to 60. So if it's above 60, we use the dose that I've told you, which is 75 milligrams oral twice daily. And by the way, this is an adult dose. I don't work in paediatrics, so I don't know what the paediatric dose is. The BNF will be able to tell you, though, what the paediatric dose is, but that's the adult dose for treatment. We haven't talked yet about prevention. That's a separate topic, which I'll come on to in just a moment. So that's the dose for normal renal function in an adult. If or renal function greater than 60, it now transpires according to the BNF. So if the renal function is 30 to 60, then we use this reduced dose of 30 milligrams twice daily. So 30 milligrams oral twice daily, and that's for EGFR 30 to 60. And then it goes down further, 30 milligrams once daily if EGFR 10 to 30. So if it's 10 to 30, then it goes down to just 30 milligrams once a day. And then, as I say, if it's below 10, then you're trying to avoid using it altogether unless it's absolutely life-threatening. So that's the doses for treatment of influenza. Let's now talk about prevention. So this is something that we do actually, probably more patients in hospital get put on it for prevention rather than actual treatment. So this is, in hospital, unfortunately, this test for viral pathogens, it takes time for it to come back. So the patient has been admitted, they've got pneumonia. Pneumonia isn't necessarily isolated because bacterial pneumonia isn't contagious in most cases. So pneumonia patients go in normal bays with other hospital patients. Then let's say their swab comes back and the chest x-ray comes back showing viral pneumonia and their swab comes back as influenza. Then we realise we put this patient that has a contagious virus in a bay with other patients, and these other patients have different illnesses and may well get very sick from influenza. So this is actually an interesting point. So this is one of the things that happened in the first wave of the coronavirus pandemic. So I remember back in March 2020, the fatality rate that we were being told for coronavirus was, or actually maybe it was slightly later than March 2020, maybe April or May 2020, we were being told that the fatality rate for COVID-19 was something like 40% initially, and that's because 40% of the people who had actually been tested and came back positive for this virus then ended up dying. And the reason the fatality rate was so high initially, or was estimated to be so high, because of course it wasn't really 40%. That virus has not killed 40% of the world, and it wouldn't have killed 40% of the world even if the vaccines hadn't happened. But the reason that it was estimated to be so high initially was the people who were getting it. The lockdowns happened, and then the only people who were getting it, the places where it was spreading, was in hospitals. So the people who were getting it were hospital patients who were already very sick with something else, and then they got this virus and they weren't then able to defend themselves properly against this virus, and so they became extremely unwell with it and got pneumonia. And that's why the fatality rate was so high initially, because the cases that were happening were hospital-acquired cases. So hospital-acquired viral infections are not good because these people are already sick, they're already compromised, and their ability to defend themselves against influenza or any other virus for that matter is reduced. So for this reason, if patients have been exposed to influenza because they've been in a bay with another patient who's now tested positive for influenza, they are put on drugs to prevent them getting seriously ill from it, and that's what they're talking about here when they're talking about prevention of influenza. So the dose is different for prevention. You give just 75 milligrams once daily, and you do it for 10 days. So this is prevention. This is treatment. So these people don't have influenza. They haven't tested positive for influenza. They've just been in contact with another patient who's had influenza. So we then put them on the prevention regimen of Tamiflu. And as I say, the dose would be 75 milligrams only once a day this time for 10 days. And that's in the context of an adult that has EGFR greater than 60. If we go back over here, it tells us how to alter that for the lower EGFRs. So here, use 30 milligrams once a day if EGFR is 30 to 60. So it goes down to 30 milligrams, and then we just change this to once daily. So this has been changed to once daily for prevention. This also gets changed to once daily for prevention. And then this is already once daily, so this becomes every other day. So change that to alternate days. So the dose is basically halved for prevention. And again, you avoid it if EGFR is less than 10. And as I say, in my experience, the majority of Tamiflu prescriptions are more for the patients who have accidentally been exposed to it whilst in hospital, i.e. for prevention rather than treatment. So those are the two ways in which this drug can be used. It can be used for treatment of severe influenza infections and also prevention of influenza infections in people who are already very, very sick and very vulnerable from becoming very ill from influenza. So I think that's all I wanted to say about this drug, so we'll end the video there. Thank you for watching.